But yeah, we'd love to welcome everybody to Bytes of Innovation. My name is Kemi. I'm the design lead here at SegMed, and I'm here with Aline Lutz, our medical director. Bytes of Innovation is a webinar series put on by SegMed. It takes place every other Thursday usually, except when we're on a little bit of a break. But we always bring in really cool speakers who present for about 15 minutes, and then we have 10 minutes or so for questions. And today I want to introduce you all to Jess Wen, who's here with us. She is with RISE. It's a research health equity initiative. It stands for Research with Inclusion, Social Justice, and Equity. And their mission is to advance equitable representation in medical research cohorts nationally by empowering clinicians and clinical researchers to report the breakdown of historically excluded populations in all future work. So as we know, COVID-19 pandemic and in general, there have been a lot of racial disparities, and we've seen that so much more because of the pandemic. And we desperately need to reduce AI bias, and especially in medical research. So thanks so much for coming and being here. Jessica, I'll turn the time over to you.
Yeah, sure. Let me share screen. Okay, so I'll get started. Hi, everyone. Thanks for having me here today. My name is Jess Wen. I am a current interventional and diagnostic radiology resident at Stanford, and I'm excited to share with you today our health equity initiative titled RISE, which stands for, as Kenny said, Research with Inclusion, Social Justice, and Equity. There you go. Okay, so I'd like to start with an excerpt from Dr. Ada Habetzian, who is Associate Dean of Academic Affairs here at Stanford. She is actually currently on temporary leave to serve as CMO of Pfizer with a specific interest in increasing equitable representation in their industry studies, which I think is nothing short of heroic. So she wrote, "Consider the hard facts. African-American women are twice as likely to die of breast cancer than any other racial group. African-American males are 2.5 times more likely to die of prostate cancer than non-Hispanic white men. American Indians and Alaska Natives born today have a life expectancy that is 5.5 years less than all other races in the US. These challenges to health equity have a historical basis. Early and late stage medical research has long lacked diversity that reflects the true makeup of the US population. While white Americans make up 67% of the US population, and that number actually updated is 60% now, so even less, they comprise 83% of trial participants, while Black African Americans and Hispanic Latinxs make up 13.4% and 18.1% of the US population. They make up only 5% and less than 1% of trial participants, respectively. Quick note from me, not included in the forward and sadly often forgotten as the invisible minority, Asian Americans make up 6% of the US population, but only 1% are represented in US clinical trials. So I did dedicate this initiative to my dad. And I was a grad student when he was diagnosed with chronic liver disease. And that's when I found out that Asian American men are 60% more likely to die from hepatobiliary cancer as compared to non-Hispanic white men. I additionally found out that although Asian Americans make up 6% of the US population, we actually account for 60% of Americans struggling with chronic hepatitis B. And I thought this was very interesting when I learned about the implications of hepatitis B. I was a PhD student, right? I thought I was so educated. I knew all of these things about HIV and hepatitis C, you know, those diseases. They were discussed in class, they were covered on the news, talked about in the media, but hepatitis B, the silent killer of the Asian American population, I didn't know anything about that. So after this talk, I hope you too will consider joining us in the fight for equitable healthcare for all. So I think when we're asking for change in any given field, it's really important to consider the current state of that field and how we got here. So when I looked into the current state of medical research, this is what I found. For decades, the medical community has adopted a don't say race approach to clinical research. And I thought this was a little weird because this is not dissimilar to the don't say gay bill that was recently passed in Florida currently oppressing the LGBTQIA student population there. And you usually think of the medical community as one interested in combating oppression, right? Aren't we trying to save lives? So I looked into why. And to answer that question, we need to go back more than 200 years to the birth of scientific racism. So scientific racism is pseudoscience, and it started with these studies that were quote unquote based in, evidence-based, and they looked at the differences between white and Black people's bodies, and they inappropriately associated these differences to mean genetic superiority or inferiority. Scientific racism gave way to nearly 2 centuries of horrific experimentation on the Black population. The most infamous of which is probably the Tuskegee syphilis study that everyone is required to learn about in order to do medical research these days, which is good. But I would argue that the most atrocious ones were the operational experiments that were conducted on the Black population. Did you know that the first ever heart transplant, that heart was taken from an enslaved Black man without his consent? And the current surgical approach to fixing abnormal connections between a woman's vagina and bladder, that surgery was developed from a series of experimental operations on enslaved Black women without their consent and without anesthesia. A lot of these are published in Harriet A. Washington's book titled Medical Apartheid. But it doesn't stop there. Scientific racism also gave way to eugenics movements, the most infamous of which is the Holocaust, in which Nazi Germany systematically massacred the entire Jewish population. So after World War II, UNESCO came together and made the statement, race is less a biological fact than a social myth. Let's break that down. That means race is a social construct. Race is something that we humans made up, right? Based on our perceived appearances. What does that mean? That means the color of my hair, the shape of my eyes, the tone of my skin, the sound of my voice, all of these things might affect my access to healthcare. It might affect my access to housing. It might affect whether or not I get promoted. It might affect whether or not I am imprisoned. And it's important to delineate here, though, that the genetic significance of self-reported ethnicity, the extent of that, the biological extent of that remains inconclusive. But race is a social construct. There's no biological basis to race. So getting back to our question, why has medical research adopted this colorblind approach? It's because after World War II, we came together and we looked at each other and we said, whoa, clearly we started scientific racism, we caused eugenics movements, we caused genocide. So why don't we just shut up? Why don't we just pretend none of this ever happened and walk away? Because clearly we don't know how to save race without perpetuating racism. But what's the problem with ignoring a problem? Sorry to be meta there. And as a physician, I like to put this in the context of patients, right? What happens when a patient walks through the clinic door and goes, "Doc, my belly's been hurting, I've been losing weight, and I haven't seen a doctor in decades." What do you usually find? Cancer. You usually find cancer. And this was actually propelled to the forefront when artificial intelligence was amplified in medical research. And we found out that we were teaching our non-human entities racism. That is devastating. But the world doesn't stop, right? What happened next? COVID-19 hit. And we all know that COVID-19 disproportionately increased the morbidity and mortality of the non-white population. JAMA recently came out with a study that showed that pulse oximeters, the devices that measure oxygen levels, they are less accurate in Asians, Hispanics, and Blacks as compared to white individuals. So if you were in the ICU and you were Asian, Hispanic, or Black, and your oxygen levels are being monitored by pulse oximeters, you are more likely to receive an inadequate oxygen supplementation as compared to your white neighbor sitting in the ICU bed next door. So the public called us out on it. New York Times published an article. Medical journals blind to racism, as health crisis critics say. Time magazine published an expose. The world's leading medical journals don't write about racism. That's a problem. JAMA was put under fire when one of their editors-in-chief made some disturbingly racist comments in a podcast. So I'll say this, the ignorance of race in medical research, it's not benign. It's a public health crisis. And where are we today? Despite efforts towards equitable inclusion in medical research, we remain far from achieving equitable representation. Published in March of this year in Stat News, even as medicine becomes more diverse, main authors in elite journals remain mostly white and male. Published even more recently in Lancet, only 43% of clinical trials report race and ethnicity. What can be done? So I've been going around asking this question, what can be done? And someone said to me, Jess, all federally funded clinical trials, they're required to report race and ethnicity. Are you sure this is still a problem? So I looked into that, and I found that in 2018, only 22% of funding came from the federal government. Actually, 64% of funding came from industry. That's you guys. You guys are really powerful. But you guys might argue that, hey, we don't do clinical research, and clinical trial research. And clinical trials are a small sliver of all medical research, right? I would agree. Let's look into all of medical research. It's abysmal. Only 5% of all medical literature includes terminology for race and ethnicity. 95% of the entire medical research community is colorblind. So it really gets down to the point of how can we, the people, just your regular everyday researcher, how can we advocate for change? So that's why we started RISE. And like Kenny mentioned before, our mission is to advance equitable representation in medical research cohorts by empowering clinicians and clinical researchers to report the breakdown of underrepresented populations in all future work when appropriate. Our website is www.pledgerise.org. And our website features 3 main components. The first is implicit bias tests. This links directly to the Harvard IATs that I think most people are familiar with these days. The second component is our pledge, which I will get to in just a second. Our third component is a research guide for anyone who's interested in kind of going above and beyond. It's really just a series of questions for you to ask yourself as you go through the research process. So for example, the first question is, what is the research problem you're trying to solve? And the second question is this problem exacerbated in communities of color? So that's something you might not have necessarily thought about otherwise. So the guide is just full of questions like these. I'd really encourage each and every one of you to check it out. Here is our pledge statement. I'll read it to you. I wish to increase equitable representation in evidence-based healthcare and thereby pledge, 1, to discover my own implicit biases and practice cultural humility, 2, to recognize that systemic inequities can lead to biased results and to minimize their impact through my own research efforts and peer-reviewed work, 3, to promote inclusion of, and this is really the only action item, report the breakdown of underrepresented populations in my research studies when reasonably achievable and appropriate, so kind of based on your own integrity, and 4, to support my fellow researchers in the pursuit of equitable and inclusive research data. And these are the standardized breakdown labels that we are proposing for race ethnicity. And this is quite powerful, right? Because in this digital age, we're really just asking for data transparency for our populations, which in and of itself is not unreasonable. But even more than that, with only 5% of the entire medical community currently reporting race and ethnicity, we don't even know, we can't even define the gap right now. But if everyone starts to report, we can start defining that gap and we can start allocating resources to bridging that gap. And while we work on that, people who are actually interested in conducting health disparity studies, those individuals or research teams can look to these studies and start powering systematic reviews and meta-analyses to supercharge health disparity studies. And this is really low-hanging fruit because most hospitals and most research centers, they already collect this data. They just don't report it. It's just discarded and ignored. So it's really low barrier to adoption, but really has really high potential for change. So this is my last slide. Sorry, I'm just checking the chat. Okay. Oh, thank you, Michelle. So I would encourage everyone on Zoom right now to open up a web browser, type in www.pledgetorise.org/pledge and pledge to rise today. And I will also take questions. Thank you so much.
Thank you, Jessica. This was a wonderful presentation.
Thank you so much. That's a really great call to action for everybody here.
Thank you both. We really believe in it.
So we are opening for the Q&A session. If anyone has questions, please send through the chat. I do have a question myself. So you said something in the beginning about self-reported race. Is still self-reported race the best way to collect people race for clinical trials and other types of medical research?
So let me see if I can go back a couple of slides. Whoops, I have some supplemental slides. So this is, race and ethnicity are a little bit confusing, right? Because there's a bit of an overlap. So self-reported ethnicity, meaning that, for example, I identify as Taiwanese American. That's my self-reported ethnicity. But my race in these breakdown categories would be Asian or East Asian, right? So the genetic extent to self-reported ethnicity likely does have some biological basis, meaning that am I genetically predisposed to some similar disease as compared to my other fellow Taiwanese Americans in this country? Possibly, yeah. But in terms of like being generally Asian, that is more of a social construct, meaning how I look and appear as an East Asian, we might be discriminated similarly because we look similar, even though our genetics may not be as similar. Does that make sense? I know it's slightly confusing.
Yes, it does.
So there are questions of, should we be doing more like self-reported ethnicity studies for genetic significance? I think at this time, trying to be like politically correct, there likely is some genetic significance to that, although we don't know exactly what that is. But we shouldn't like then extrapolate all of that. If you do like a study on purely Taiwanese Americans, you should not extrapolate that also to Chinese Americans, right? Because there might be some differences there. And I see a question here from Martin. How do you convince populations who have suffered from medical research to participate in current research? How do you gain that trust after so much harm? There was, I wish I put this graph in this presentation. There was a presentation by Dr. Jackson at MGH looking at the factors/barriers to including historically underrepresented populations in medical research. And it actually showed that mistrust is a relatively low factor as compared to other factors in convincing them to participate in medical research. I think the like higher ones were actually language barriers, time, like being tech savvy. So I think mistrust has been historically something that we feared to be a huge barrier, but it's actually not necessarily. I think if we take interest in those populations, they do generally trust us. And I think now with there being more diversity in the medical force, that's really helped to combat that mistrust. Hopefully that answers the question.
I do have another question, Jess. So we at SegMed, we collect data sets for validation of AI algorithms. And many times we want to represent the US population, for instance, but we don't have the race info associated with the data. So we basically work with retrospective data sets. So do you think we could use things like geography or the type of the population that a certain hospital assists as a proxy for race in this case?
I think so. I think yes, to a degree. If we go to, sorry, if we go to our website, let me just pull it up. Because there are breakdowns or evaluations. Let me share a screen again. So I really like this graphic. If you go to the next page, it kind of shows you the breakdown of each state by race. And you can see that luckily in California, we are pretty diverse. And you can see that in other states, we are less diverse. So I think like citing this, you could say that, oh, because we are in, this demographic, we likely have, more of like Hispanic or Asian population in this region based purely on these demographics. But I would say that most hospitals do collect race data. They unfortunately, usually they reflect the current racial categories that are recognized by the Office of Management and Budget in the federal government, which is what advises the US Census Bureau. The problem with that is that the Middle Eastern and North African population is not included, and therefore all of their data is basically erased, which is really sad. Something else that we're working on. But I think a better way would be to get the race data from the hospitals, because that would just be more accurate.
Yeah, for sure. Mm-hmm. Yeah, thanks. And that's a good resource, by the way. So Michelle is asking if you could tell us about your upcoming projects and work, and if people could reach out to you and how can they engage your work.
Yes, if you are interested, we are always looking for more people to help out, especially you guys who may know how to code. So our current, let me again stop sharing and then reshare. Whoops. Oh, where did share? So basically right now we're trying to basically hit it on all fronts, right? So we're talking to journal editors, we're talking to policymakers. I have meetings with FDA, I have meetings with the National Academy of Medicine. And my next upcoming meeting is a meeting with the Journal of the American College of Radiology with their team of editors in chiefs. And we're seeing if there's an easy way that we could make submitting that breakdown just like super easy. So like maybe we can make part of the submission process where you just upload your data set and it spits out the table that we want, right? Like this table. And then so, because their concern from their end is like, we don't want to deter authors from submitting to our journal. Like if this is an added barrier, and none of the other journals are doing it yet, right? If all journals are doing it, then it's not a problem. But if this is an added barrier to our journal, then they might just go to a different journal to submit instead. So we're trying to come up with a way to just make it really easy for authors to submit that. So if you are interested in helping out with that, please reach out to me. I can, or maybe Martin or someone can send out my contact information. But yeah, so basically we're just trying to hit it from all sides, get people to report data, get people to really support, data transparency from a racial perspective, really trying to fight color blindness in medical research.
Awesome, thank you.
Yeah.
Well, thank you very much, Jess, for your presentation. It's very inspiring to all of us. And Bytes of Innovation will go into a summer break, and we'll be back in September with a new series of Bytes of Innovation. Thank you all for being here today.
Thank you so much for having me.